So what happens when a drug that can cause psychosis also makes someone feel like they can finally focus? Today we're going to untangle a really dangerous knot at the intersection of ADHD and stimulant addiction. It's a diagnostic puzzle where one wrong move can have absolutely devastating consequences.
To really understand what's at stake here, let's start with a story. This is about a guy we'll call Dale. He's 32.
So Dale started using meth just occasionally, at parties, but his use spiraled out of control fast. It went from small amounts to a full gram every single week.
And after about a week of using it daily, things took a really terrifying turn. Dale developed severe paranoia. He was having hallucinations. He ended up in a psychiatric unit for 5 days. Thankfully, the psychosis did clear up.
Now that experience was obviously rattling. Dale managed to cut way back on his use, but then he asked his doctor a question that gets right to the heart of this whole issue. He said, "I could concentrate so much better on meth. Do I have ADHD?" Now that might sound shocking, but it's an incredibly common and honestly logical question that clinicians hear all the time.
And Dale's story isn't some rare exception. It really shines a spotlight on this powerful, well-known link between ADHD and substance use, and it's a connection that's very much a two-way street. First, let's look at it from one direction. If you have ADHD, your risk of developing a substance use disorder is double. And it's not just about struggling to focus, right? It's the impulsivity that can come with untreated ADHD that makes substance use and all the dangers that follow far more likely. Okay, now let's flip that coin. If you look at people who already have a substance use disorder, the rate of ADHD is 5 times higher than in the general population. This massive overlap is exactly why Dale's question is so common, and why getting the answer right is so critical.
But taking it seriously doesn't mean it's easy. Oh no. In fact, trying to diagnose ADHD in someone with an active substance use disorder is like navigating a minefield. The symptoms overlap, and the substance use itself can actually mimic ADHD, which makes a simple diagnosis pretty much impossible. So you might be thinking, okay, but can't you just use one of those standard ADHD screening checklists? I mean, it seems like a logical first step, but in this specific situation, it's a deeply, deeply flawed approach.
Here's a great way to think about it. Using a standard ADHD screener here is like taking a metal detector to a beach to find gold. Sure, it's highly sensitive to metal, but you're going to end up finding way more rusty bottle caps than actual treasure. And the data really bears this out. The chance of that screener being right drops to just 26% in this population. So think about that. For every 4 beeps from that metal detector, for every 4 positive screens, 3 of them are probably bottle caps. They're false positives. You're getting it wrong 74% of the time.
So how do you do it right? Well, on the left, here's what not to do. Never ever diagnose from a screener alone. And this is a big one. Don't diagnose based on how someone responds to a stimulant. Just because meth helped Dale concentrate doesn't automatically mean he has ADHD. Now on the right, this is the proper, careful work. You have to prove that symptoms were there before age 12, you need to talk to family or partners, and you have to rule out other things that can look like ADHD. The main takeaway is that patient history, not just their current symptoms, is the gold standard here.
Okay, now we have to talk about the most serious risk in this entire equation, stimulant-induced psychosis. This is where a diagnostic misstep can have truly devastating consequences. The risk profiles here aren't even in the same universe. With prescribed stimulants used correctly for ADHD, the risk of psychosis is about 1 in 660. But with street drugs like meth or cocaine, research shows that up to 68% of users, that's nearly 7 out of every 10, will experience psychotic symptoms. The difference in danger is just staggering.
And here is a statistic that should stop everyone in their tracks. For patients like Dale, who have already had a drug-induced psychotic episode, if they're discharged and then re-prescribed a stimulant, 45% of them are readmitted to the hospital within 18 months. It is an extremely high-risk situation that demands extreme caution. So, given these immense challenges and these very serious risks, how do clinicians find a safe and effective path forward? Well, it's all about carefully balancing the potential benefits of treatment against the very real dangers.
So what's the right approach? Experts recommend these 4 principles. First, you have to treat both issues at the same time. You can't just ignore one for the other. Second, weigh the risks. Stimulants should only be considered if the benefits clearly, and I mean clearly, outweigh the serious dangers. Third,
Always consider the alternatives, like non-stimulant medications and behavioral therapies. And finally, if stimulants are used, the monitoring has to be intense. We're talking pill counts and using long-acting formulas.
And it's so important to add a major caveat here. The evidence for treating a stimulant use disorder with, well, another stimulant is surprisingly weak. The main study people point to define success as just 2 weeks of being clean, not long-term recovery. And the positive effect they saw, it was in cocaine users, but not even in amphetamine users. The bottom line is that clinicians are often making these high-stakes decisions with very limited data.
And that leaves us with the central challenge for clinicians, for patients, and for the entire healthcare system. When the lines between a symptom, a side effect, and a disorder are this blurry, the most important task is finding a path for people like Dale that helps without causing even greater harm. And that is the tightrope doctors have to walk every single day.